Thank you very much, and I really appreciate this invitation and opportunity to speak to all of you today. So let's get started. I'm just going to share the screen. Hopefully things will work out fairly easily. So let me just get this rolling. If you let me know, when you see the screen, the full PowerPoint, you can see the full PowerPoint. Yeah, Anna, yeah.
Yes.
Okay, perfect, awesome. So thank you very much again, and I think the presentation today is timely, certain in view of the heat wave that's been experienced in BC and certainly out in the western parts of the US. And today I'm really going to cover two components: the heat stress, the effects of heat stress in vulnerable population, the elderly and patients with chronic disease. And I'm also going to then also take a look at the effects of heat stress in our aging workforce, and give you some valuable insights into the recent work that's been conducted over the last few years to help you, again, better handle and understand the impacts of heat stress. So it's without question that essentially what we do know is that we are experiencing a rise in temperatures globally, and the impact is that there's a large number of greater number of people are being exposed to these extreme conditions. And I think this is not going, certainly is not going to get better. It's going to get worse over the decades to come, and we have to be prepared for that. To be prepared, we need to understand how best to protect our most vulnerable. So in terms of achieving that objective, I think we have to understand the impacts that extreme heat can have. And certainly I think the heat wave in 2003 is probably one of the landmark periods in our history where we saw 70,000 excess deaths recorded in Europe during the 2003 heat wave, and certainly in Russia following in 2010. But sadly, in BC, as was experienced just recently, just over 800 people have lost their lives during this brief extreme heat event. And based off the news that I was able to see today, even the heat temperatures are continuing to be elevated in BC, which really poses a danger to the most vulnerable, including workers. Before we get moving, I do want everybody to be on the same page, and perhaps many of you do understand the basics of thermal regulation. It's an area of research that's not well studied in terms of work that's conducted relative to other areas, but I think we need to understand some basics. So essentially, when you're sitting down there right now, as I would be right now, I'm generating heat, and I'm hopefully in heat balance, unless I'm getting a little stress speaking to you. But essentially, my body is essentially gaining heat, and I'm adjusting my heat loss to make sure that my core temperature remains stable. So I'm essentially modulating my skin blood flow and sweat production. So essentially, again, these two avenues will help us achieve heat balance. But when we talk about metabolism, we're also talking about the fact that when we do any kind of physical activity, we generate heat. We're not a very efficient system, and probably only about 15% efficient. That all of the energy that we take in, essentially, and that energy that's used to do muscular work is lost in terms of heat energy. So that is an additional heat gain. The key challenge that we face when exposed to a hot environment is the fact that essentially that hot environment adds to the burden that's placed on the system. We end up gaining a little more heat. Why is that? Well, number one is that skin temperature, certainly if air temperature exceeds skin temperature, then you're going to see that essentially the system gains more heat. So what we do lose in terms of our capacity is the fact that we really lose less. We're unable to lose heat via dry heat loss mechanisms. In fact, we gain heat into our system. The only avenue of heat loss that we have available to us thereafter is the production of sweat, and hopefully the evaporation of that sweat. And I always like to hear people talk about that they're great sweaters, but that doesn't mean anything, especially if the sweat just drips off your body. It provides absolutely zero cooling benefit to the individual. So to put things in perspective, again, I think we have to look at how different people respond to the heat. We're not all built the same way. And there are reasons that essentially, there are multiple reasons why, for example, if I was exposed to a heat stress and somebody that essentially of my age, my size, same sex, and may have type 2 diabetes, may be exposed to that same level of heat stress, they may experience a certain amount of heat gain when exposed to that heat stress, and they'll achieve a core temperature. I might achieve a core temperature at a point A. But if they have chronic disease like type 2 diabetes, that may cause impairments in their ability to lose heat, which would cause them to store even more heat, causing the shift then to a much higher core temperature for the same exposure. Consequently, that may lead to heat-related injuries. So when we assess the effects of heat stress in different individuals, it's not as simple as simply looking at whether they are young or older. We also have to take into account a number of intra-individual factors that consist of sleep state, medication use, as well as duration of exposure, number of consecutive days of exposure. All these factor in and how we study or understand the effects of heat stress. And we've studied all of these different mechanisms. Another challenge that we have in really understanding the risk somebody experiences is quantifying the heat exposure. It's not as simple as simply looking at a thermometer and saying, how hot is it? The reality will be, and we hear a lot about this, that essentially, because we live in Canada, temperate environment, that we're less at risk versus somebody that may live in the southern states where temperatures are much higher. Simply stated, the threshold for heat rate related mortalities is simply lower in Canada, and certainly would be lower in the more northern provinces or northern areas if in fact temperatures were elevated in those regions as well. You would see that heat related mortality would just be at a lower threshold. But even within the urban environment, within a large city, you'll have variations across different sectors, different neighborhoods. And that's to do with how the built up environment plays into the equation. Then we have building types as well. Some structures are highly insulated. Some structures have air conditioning. Some structures have multi-level residence. All these play into it as well as to who might or might not be affected during a heat wave. And then we have to consider the heat source. Again, physical activity is an easy source of heat. And certainly when you are perhaps cooking in the home, you're generating other heat within the home, causing temperatures to rise. And then we have the physical state of the individual, being fitness, health status, and other factors that really define what that exposure is going to be like. Just try to get my laser pointer here. So essentially, that is important for us to take into account. So looking at the urban variation, I think this is important because when we look at extreme heat events, typically we might refer to a heat alert based on a specific temperature. It might be a designated temperature coming from the airport, but how accurate is that in protecting all individuals? I just said to you early on that essentially there are individual factors that affect one's ability to lose heat, but beyond that, there's also the variations within the exposure area. So within different neighborhoods, in this study conducted in Philadelphia, we can see that just being within one neighborhood, your risk of heat-related mortality is much higher vis-a-vis in some other areas. And you can see how this distribution varies across the different sectors of Philadelphia. And surprisingly, the one thing I hear a lot, especially when we write grants, and it's always a bit of a quandary why we get these comments, but I hear sometimes that people say, well, if heat's a problem, just take them out of the heat. It boggles the mind. And I want to go back a year, 2020, COVID-19, isolation of the most vulnerable. These individuals, especially those in long-term cares, were isolated for long periods during the day with only periodic times to go and eat lunch in a common room. These individuals faced high indoor temperatures. And even here in Ottawa, we saw temperatures that exceeded 30 degrees in some rooms. The reality is that in this study conducted in Detroit, it showed that even in a non-heat wave situation, so these are just normal summer temperatures, that we essentially saw max temperatures of 35 degrees Celsius. So it's not impossible. And what we do see is that progression in temperature will increase over the summer period, which is another important point, is when that heat wave occurs, because again, we'll see later on about adaptation over the summer. But remember that in fact, temperature will progressively get hotter indoors, depending on the type of building. And you can see here, just from the imaging, satellite imaging, just the risks different communities will face as a function of rising temperatures. And obviously the red areas indicates a high danger zone. So you can imagine that the heating of the homes will cause heating of the homes indoors. And to that point, a study conducted in the Netherlands, and this is an important point, while it's a temperate environment, perhaps a cooler environment, it does represent some of our areas in Canada. And I think this, again, this was a non-heat event, but the changes show you over time what happens to indoor temperature as a function of changes in outdoor temperature. Even the living temperatures indoor can be hotter than the outdoors. And this becomes problematic if you're living in these conditions that will probably be even hotter when you have an extreme heat event. And particularly, we see the effects on bedroom temperature. And that is important because in this study that was conducted in the elderly people, many of the individuals felt very warm or uncomfortable. And you can see it got progressively worse as the summer moved along. And you would, again, and we do know that elderly people will get adapted over the summer, and I'll show you that data later on. So in that context, then, what's important to understand is that progressively, as we see over here, over successive weeks in the summer, you can see that there are a number of heat-related symptoms that show us that the elderly just don't do as well over the summer period. Even though there may be some slight adaptation, you'll see that there are a number of heat-related symptoms like sleep disturbance, concentration problems, fatigue, thirst, excessive sweating that really take away from the quality of life and again create a physiological burden on the system. Again, it may seem rather benign in terms of looking at some of these systems, but imagine having disrupted sleep and living in these extreme heat conditions day after day. So for our work and the work that we've done over the past number of years has been really directed on understanding all these different factors and how it can affect somebody's capacity to lose heat, their physiological capacity to dissipate heat. Why is that important? Not only do we want to understand what the effects of aging are on the body's ability to...
It's okay, go on this side. I just wanted to leave the water and boil.
Sorry, how the calorimeter will essentially, when we're doing these kind of studies, what we want to know is not only how aging will affect the body's ability to dissipate heat, we also want to define very specific thresholds. So we know at what level of heat stress, potentially, a person with diabetes may be at greater risk. So we have the world's only whole body air calorimeter, and you can see it opened up here. It would be closed. So you see one of our elderly patients inside of this room. And what that system allows us to do is measure very precisely the amount of heat dissipated by the body, both evaporative and dry heat exchange. And we can measure very precisely the amount of heat that the body stores. And as the body stores more heat, temperature will rise. And so let's take a look at some of this information. So in one of the earlier studies that we started in around 2015 and subsequently published this work focusing on young to older adults, and we had elderly people exposed to 3-hour extreme heat events. Now you have to understand that back then there was not a lot of work done in elderly people, and exposing an elderly person to 44 degrees Celsius, 20%, was certainly raised eyebrows from the Research Ethics Board, because they were saying, well, geez, you're going to put these people at risk. But again, exposing individuals, if I take the same person, I exercise them, they're going to experience the same level of heat stress. So it's a bit of a challenge to conduct this research, but let me show you some interesting results. So what happens when you enter the heat, a hot environment? Your body gains heat. Remember what I said early on, when temperatures are greater than the skin temperatures, the body gains heat very rapidly, and you can see that by the blue dots. Now the white circles, not dots, but the white circles show you the rate of heat loss. So as heat is gained by the body tries very quickly to offset that. And you can see here that by about 2 hours, heat balance is achieved. Now, I want to put this in context. If you or I were going to go out and exercise right now, it would take you, so long as the conditions are compensable, about 35 to 45 minutes to achieve heat balance. What's shocking is that it takes this long for even a young adult to achieve heat balance, which shows us the way we thermoregulate during a passive heat stress and an exercise heat stress is somewhat different. But let's take a look at an older adult. Why are they at greater risk? Well, what we're seeing after 3 hours is that there's a separation between heat gain and heat loss. So we don't have a balance. Young, they're balanced. Heat gain, heat loss, balance. Core temperature elevated, but now stable. An older person, no balance. That means core temperature was rising quickly, but attenuated. So it's still rising. So what you see is they store about 1.7 times more heat in this 3-hour heat exposure. Now let's migrate to look at what about diabetes? We know from our work and work of others that patients with diabetes have a potential reduction in skin blood flow, that essentially that impairment skin blood flow will cause potentially greater heat gain. Why? because if skin temperature is lower, that means the skin blood flow is lower. That means skin temperature is also going to be lower. And the gradient between the air and the skin is much higher, so they'll gain more heat. Is the evidence there? Well, let's take a look at it. If we look at the blue line here, you can see that this rate is much higher. The rate of heat gain overall is much higher in a patient with type 2 diabetes. So they're gaining more heat. But we look and we see that the values are roughly the same. They store about the same amount of heat over that 3 hours. So how's that possible? Well, to offset that, what they had to do is increase the rate of sweating so that evaporative heat loss would increase. So what it tells us is while they may have the exact same core temperature, the patient with type 2 diabetes may be at risk down the road if they face or maintain that exposure for prolonged periods. Why? Because sweating is sustained at elevated rates. If they sweat and don't hydrate adequately, what you're going to see is a gradual dehydration in this individual and a greater burden on the cardiovascular system just to try to maintain perfusion to the skin and release that heat. All right. One thing I always hear about is when we talk about heat waves, it's all about ambient temperature or air temperature, I should say. It's not all about air temperature. You can have deadly heat at lower temperatures if humidity is high. Why? Because when air temperature is lower and humidity is high, or even if it was high temperatures, what you have is a situation where the air is saturated with moisture. Well, the whole point of evaporation of sweat is that you want to essentially take that sweat, evaporate it, and that moisture will fill the air. Problem is, if it's saturated, it's ineffective, and you're going to get a lot of drip sweat. So what you see if we take two different conditions, a young and older person in dry heat, as you can see 20% relative humidity, you see that the older still have these age-related impairment. This is a 2-hour exposure. So the higher the bar, the higher the increase in core temperature. And you can see if we then expose them to 60%, they store this much more heat. So even a slight increase in humidity can increase the amount of heat stored in the body by nearly twofold. So humidity matters. And even in a lower temperature, you can still have you can still have heat-related injuries. Very important point to remember. So let's take a look at some of the other work that we're just finishing now. I'm giving you a first glimpse into work that we're going to be submitting for publication very, very soon. What we have here is we said, great, we're understanding what's happening in the elderly when they're exposed to heat. We see over 3 hours, they're not achieving heat balance. Well, that raises questions. Does that mean that their core temperature is going to rise progressively over a day-long exposure? That's a big question, an important question. Are they able to compensate for that exposure? So in this study that we're completing, that we just completed, we again isolated our patients within the calorimeter, and we did a 9-hour day-long exposure to assess the effects of on whole body heat exchange. I'm going to present to you the rectal temperature. So what you're seeing here is over that 9 hours, you can see that they do eventually achieve stable core temperature. But in the first few hours, you see, like we saw before, in the first 3 hours, by 4th hour, they started to achieve heat balance. So that means now rate of heat gain matched by rate of heat loss, but it took that long to get that heat balance. That's important. And relative to the younger individual, we still see, again, they achieved a heat balance much at a lower temperature, and they have a greater capacity to lose heat because of that. You can see that essentially the older do exceed what would be the safe conditions that WHO recommends, being that core temperature would be lower than 1 degree. And we can certainly see a number, this is your standard deviation, number of the patients had temperatures well above that, with some up to as high as 1.8 above baseline resting temperatures. Now, the conditions that I've shown you thus far are in the more extremes and possibly more likely reflective of the heat wave in BC at the end of June and start of July. And that would be humidex between 40 and 50 degrees C. In Ottawa in 2018, we experienced a very extreme heat event in which we had a humidex of 47 degrees, humidex of 47. And again, those are certainly the extreme. Now, the reality will be is when we look at the conditions indoors, those conditions don't always reflect what's outdoor, but they get very, very hot. And therein lies the problem. It's not that have elderly people sitting outside an extreme heat event. That's not the issue. The issue is that elderly people spend the vast majority of their time indoors, and some, because of their situation and long-term care residents, don't have an option. They'll spend their whole day indoors. So one of the things that we have to concern ourselves is, what should the indoor temperature limit be? The World Health Organization recommends an upper limit of 32 degrees, albeit they're certainly recently looking at revising or have revised this recommendation. Now, astutely, I think, looking back at what Toronto Public Health recommended 26 a few years ago, I think this was a good call, and certainly was based off of heat event data on mortality related to a heat event in Ontario and Quebec. And I think that really set the stage for what might actually be an appropriate threshold. So let's take a look at that. We are interested in understanding, first of all, what should that indoor temperature limit be? So again, to put it into perspective, if we look at the humidex spectrum over here, again, you're going to have the very hot condition that we're going to test, which is going to be around the 36 degrees temperature, and we're going to test all the way down to the cooler condition, which would be your temperate room condition. So let's take a look at what we see with rectal temperature. So our elderly patients aged 70 to 80 were not isolated in a calorimeter this time. It was a large chamber, so they had a bit of more freedom, but they did sit there all day long, and there were clinical tests done throughout the day. And you see here, we had them exposed on one session at 22, 26 indoor temperature limits suggested by Toronto Public Health, 1 degree Celsius, just below that of the WHO, and 36. Now, these are temperatures, again, that are not uncommon within the indoor temperature environment. As I said, in Detroit, maximum temperatures did reach 35, and we do know that some homes, that these temperatures can even be higher. So these are realistic values. And when we look at that, sorry, just to go back, what we do see in terms of core temperature, when we look at the blue line, is that we essentially see that it's pretty stable. There's really no increase in hyperthermia for the individual. And same for the 26 degrees Celsius or the Toronto Public Health recommendation. But when we migrate or move up to the 31 degrees Celsius, we clearly see that there's an excursion in core temperature over that day-long exposure. They do achieve heat balance at some point. Certainly at the 36, it's much higher. Now, it's not that that core temperature is dangerous by itself for that single exposure, and that's something to remember. What's important is that that same core temperature at 36 or even at 31 degrees is the equivalent that you might even see during exercise. If I take that elderly person and do a low to moderate intensity exercise, I will still see that excursion in core temperature about that same magnitude. The challenge is that that is a burden on somebody when they're exercising. It's no different when you're exposed to heat. That creates a physiological burden that, if sustained, can create heat-induced fatigue, heat exhaustion, and other factors, even though it's a low level of hyperthermia. So let's take a look now at the heart rate response. What are we seeing? We're essentially seeing that the burden placed on the heart, if we look at the cool to the hotter condition, the burden placed on the heart becomes greater. And again, imagine, why is that? Well, again, remember that when we generate heat, the system is trying to increase blood flow to the skin. And to do that, obviously, it has to dilate the vasculature. In doing so now, to maintain blood pressure, the heart has to work harder to maintain perfusion through that vasculature. So the heart is working harder. So that means for an elderly person who may be sedentary, that can lead to fatigue and distress. What about blood pressure? Well, this is a very interesting observation, because in our day-long exposure, especially in the elderly people, what do we see? It's surprising to see that even in the most extreme heat condition, you can see here in the cool condition, normal blood pressure, and then there's a real gradual fall, even at 26 degrees, in a person's ability to regulate blood pressure. In these two patients over here, we observe collapse in these two individuals. What we do see in this day-long exposures is that the elderly adults really don't recognize the fact that they're hyperthermic. It's not until very late into the 7th hour that they start to show signs of distress, that they start to recognize that something is not going right here. Most of them don't feel that level of heat stress. They're just not sensitive to it. And we know that that happens. And also, one other clinical test, some of you might know, is the 30 to 15 ratio, which is essentially an evaluation of changes in heart rate, which is performed in initial phase of adaptation to an orthostatic stress. So you're looking at the maximum minimum response in heart rate. And what you're really trying to understand is the activation of the central nervous system to a stressor. So going from rest to upright can lead to syncope. And we see that dramatically here. So we see that even at 26, while we may not see that level of hyperthermia, we're seeing an impairment in somebody's ability to deal with these kind of stressors. Now, why is that important? That means that potentially during an extreme heat event, somebody could collapse, fall, as a result, have a fractured hip or fractured skull. It's not impossible. So we do see that below 1.04, that is considered a significant dysfunction in their ability to, again, maintain stable posture. So we can see that over here. All right, let's migrate to potential heat mitigations. And I know that many of you have been advocating for the use of, or promoting the use of cooling centers. And I think that's extremely important. We're talking about using air conditioner. And again, not everybody has air conditioners. In fact, many individuals just do not have access. We know that in Quebec and in Ontario, long-term care residents, 90% of them do not have air conditioning. Sadly enough, they're relied only upon access to a common room to get any form of cooling. And again, I think the challenge here is really trying to understand the benefits of a cooling center. Just to what extent does it actually help protect the vulnerable? Let's take a look. We do know that it's any form of adaptation, heat mitigation strategy is beneficial because it lowers that risk. But we need to understand exactly what the benefits are. So looking at the work that we're just in the process of completing, again, we just completed this work, again, in partnership with Health Canada. What we did here, if you can recall the tracing I showed you earlier during a 9-hour exposure within the calorimeter, the patients were then at a separate group was exposed to at midway to a 3-hour or 2-hour cooling period, as you can see over here, after which then they re-entered the calorimeter at extreme heat. And so what's important to see here, and this is important, again, we do have the calorimeter-based data that gives us body heat storage. What we see here is a rapid decline in core temperature in that cooling period. But let me say one thing. When we're looking at heat storage and the difference, what a calorimeter does, imagine if I can infuse 100 marbles into your bloodstream. Now the calorimeter will be able to tell you that there's 100 marbles in your body. Now, if I was to insert a rectal probe and it is able to sense these marbles, it might say, I recognize there are probably 35 around the vicinity. Unfortunately, it doesn't know where it doesn't know that there's 100. It can only tell you that there's 35. So it actually is only a surrogate measure of the amount of heat stored in the body. So while core temperature is going down here, I would tell you data that you're not seeing is in fact, there's still a huge residual heat load here. So core temperature is in part going down because the skin is cooling and just how the blood is redistributed causes this slight drop or a marginal drop in core temperature. But that said, it's still a drop and it's still protective. And what we do see, unfortunately, is that the minute they get back into the heat, the rate of increase in core temperature is much quicker than it was before the exposure. So while cooling centers are effective, no question, it will also help reverse that cardiovascular burden. You have to remember as well that you have to provide guidance to the patient, because if they go back, let's just say they've come from the cooling center and they've walked there and they walk back, in no time at all, by the time they get back home, they'll have that core temperature will have gotten even higher or even faster to increase to a greater rate. So we have to be careful and explain to the patient that that benefit may be short-lived. Let's transition to exercise. We're going to look at how heat stress will affect workers or just people engaged in physical activity. One thing that we know is in the absence of having appropriate thermoregulatory abilities, and that means increased skin blood flow and increased sweating, it would not take long for the body to reach very elevated temperatures that essentially would kill you. So it doesn't take long. So, but you have to remember that as we age, unfortunately, we're going to see a deterioration in that capacity when we get chronic disease or when we are sedentary. So let's take a look at that. So one thing we have to remember, and I'm going to talk today just again in the context of occupational heat stress. We have an aging workforce and we have extreme heat events. So I want to talk about this, but it still applies to those that are physically active in the heat. One thing that we know, unfortunately, as we get older, as I've discovered myself over the last 2 decades, is it doesn't matter how much I train, essentially we're still combating the effects of aging across our various physiological systems, that there's a gradual deterioration. Well, the same holds true when we talk about a thermal regulatory capacity. So ultimately with aging, work performance is reduced. The problem is that extreme heat exacerbates that quite profoundly. And essentially that can create significant problems to a worker. Now, the challenge we face today, and I see it across many industries, certainly the mining industry, the electrical utility industry, we see an aging workforce. And that's seen across Europe, it's seen across the United States and across Canada. And that becomes a problem because, as I'm going to show you, aging is associated with dramatic reductions in the body's ability to dissipate heat. And as you're going to see, it's an important point to consider, especially in view of existing guidelines, which don't offer the level of protection to everybody that's necessary to safeguard their health and well-being. So many of you probably have used different indices recommended different indices to industry to use in terms of helping them monitor their workers. Some may use, for example, the ACGH threshold limit or action limit values, and these are what you're seeing over here. So essentially, these exposure limits are based on temperature, clothing worn, and the work intensity, and it gives you a very specific exposure limit that you should adhere to, at least try to adhere to prevent potential dangerous increases in core temperature. So what do we know about these guidelines? The problem with the guidelines is that essentially it's a one-size-fits-all approach. These guidelines do not consider the age of the worker, the sex of the worker, the state of health of the worker, their sleep state, number of consecutive days that they may be working, and other factors that essentially can compromise their capacity to dissipate heat. These are real factors that play into how we should be monitoring our workers. So, where's the evidence to say it doesn't work? Well, a number of years ago, we undertook that challenge. We essentially did a first scale study looking at older workers, just under, on average, mean average age of around 60 years old, 58 to 60 years old. And we assessed the ACGI TLVs. And what we're looking at here again is what we have here is we use moderate intensity work in this trial. Why did we use moderate intensity? Well, we've conducted years of field work in electrical utility across North America, Texas, Arizona, different areas across North America, as well as in Canada. And we also assess workers in the mines. And we know that on average, during a day-long work shift, it's roughly the largest proportion of work done is moderate intensity work. So we wanted to sort of simulate that. And what we did is we assess workers using a simulated work model in using the work to rest ratios or continuous work inside a calorimeter so we can measure it very precisely. And the first challenge was we did the continuous work. So you see over here that essentially, again, exceeding that bar would be, again, the limits that would be suggested by the ACGH guidelines being, or World Health Organization, when you exceed it by a degree, then you're potentially putting your worker at risk. Again, what you see in the young individuals here after 2 hours, and that's the open bars here, the white bars, you see that on average, most of the younger are protected. But the older, is the gray bars over here for this condition, you see the vast majority are not protected. Now, the reason you see the 4 hours is an extension based off the rate of heat storage. And the reality is because most workers, again, might do a pre-lunch work shift. So that's 4 hours, take the lunch and then go off for another 4 hours. Based on those projections, you can see that even young would be at risk. Certainly the older would be experiencing moderate to severe hyperthermia. Of course, some of these are just not, these are theoretical based solely on the rate of heat storage. But even when we go to the work to rest of 3 to 1, which if we increase WBGT, you can still see again that the young work are generally protected, but the older are not. And again, this raises many questions about the ability of these existing guidelines to protect the most vulnerable. So what about aging? And this is important. So before we move it forward anymore, I want everybody to think about if you've ever taken an exercise stress test, a VO2 max test. You want to test your fitness, you're all excited about doing it, and you go out there and you do a treadmill test, right? So if you've done a VO2 max test, you know what it's like. Or if you've had a heart check to verify if you had any heart conditions, you're going to do an incremental exercise test. And the purpose behind that essentially is to measure your aerobic capacity, the maximum ability of your active tissue to utilize oxygen during exercise. So using a very similar concept, we developed a test that's conducted in our calorimeter that essentially allows us to measure the body's maximum capacity to dissipate heat. And we do it as an incremental model, but this is a little longer. It's not these 2-minute increments. up to 10 to 12 minutes. This is a 90-minute test. So you do 30 minutes at light, 30 minutes at moderate, 30 minutes at vigorous with 15 minutes recovery. And by doing that, you can compare groups and see at what level of heat stress do you see impairments and what is that physiological capacity to dissipate heat. So based off of this, we have here the data that looks at the effects of age. And we're looking at the lifespan here. So you can see we have women in red, men in blue, and you can see them here, the responses in moderate to vigorous. Where we see a difference in age-related effects are when we get to moderate to vigorous work. And you can see the age-related decline across the lifespan in adults age 18 all the way to 70. And what we do know is that essentially that decrement in person's physiological capacity to dissipate heat is about 4%. And in women, it's 4% lower. Now, why is it different? It is not, it has to do with the end organs themselves, the skin vasculature and the sweat glands that differ in the mechanisms of control. That's why we see slightly lower capacity to dissipate in women. So when you look at moderate intensity work, if I was to do intermittent work, this is the effect. An older stores this much more heat relative to younger for a moderate intensity exercise bout. Now, again, coming back to the idea, we can't forget, even though we may do studies in dry heat conditions, we can't forget the superimposing effects of humidity. When you look at, for example, 30-year-old performing exercise in dry heat, this is how much heat they're storing. That's how high core temperature will get, but way higher, 1.5-fold greater in a humid condition. And you can see just how much hotter an older person will get when performing in dry versus humid heat. Now, in context of aging, one thing that we do know is fitness matters. And this is something that I've been advocating across the board when I speak to executives across different companies about the importance of using, health training programs or health programs, because it's important. Having people engaged in vigorous exercise is important because it can offset age-related changes. Case in point in this work that we showed, that essentially if you take a middle-aged trained person and compare them to an habitually active worker, they have the same response in terms of their capacity to dissipate heat. So they have the same core temperature during exercise in the heat. However, if I have a trained 50-year-old person and an untrained, what you're going to see is that untrained person actually responds very similar to an older active individual. So fitness matters in the context that it will improve your capacity to dissipate heat. And we know that exercise has a myriad of factors or benefits on other physiological systems. What about diabetes? So I'm older, I have diabetes. How's this going to affect me? Well, in our first study a number of years ago, we assessed the heat loss responses in patients that were relatively sedentary. So we did low to moderate intensity work, was relatively low. But you can see that after the 60-minute exercise, they stored more heat relative to their healthy counterparts, the white bars. That's the area in pink. That's how much more heat they stored. Now, when we assessed and did a subsequent study later on and looked at the physiological capacity to dissipate heat, so it's just like doing your VO2 max. What was their aerobic capacity? Well, what was their maximum physiological capacity to dissipate heat? We saw that it was 20% lower. That's huge. That means that essentially I can do less work, or I can be exposed to a high heat stress condition for less time. Now, importantly, these have huge effects on work performance. So let's translate this information now to the worker. Let's go back to, again, the ACGIH guidelines. We just looked at them earlier. And in this large-scale study that we just finished and published, what we did is we assess how workers will respond under 6 different ambient conditions. Now, we used, in this case here, again, moderate intensity work. We used a WBGT of 25 as that sort of threshold. And we compared responses in older adults with type 2 and older adults with hypertension. A subgroup also did the conditions in the light gray area. So we had a condition that would be above, so the 24 and 16 were below the action limit threshold for continuous work, which was 25 WBGT. And we had conditions above that. And why is this important? Number one, this work is important because number one, we see that if we look at our work in the electrical utilities, as well as mining, the vast majority of workers always exceed 38 degrees. In fact, in some of the workers that we tested in Texas, we saw a number of them reach levels of 40 degrees doing their work outdoors. So it's a problem. And the problem is how this can affect the older worker. So let's take a look. So in this work, we want to understand just how workers may be affected. So what you're looking at is a WBGT below the recommended action limit value. So that means it should be safe if they were to perform prolonged exercise at a WBGT of 16 or 24. Well, surprisingly, we still see a number of workers, even at 24 and at 16, that are essentially exceeding this 1 degree upper limit. Again, the guidelines are there to limit the increase in core temperature above 1 degree. Again, you're going to see excursions above 1 degree during a work session. That's a given. It's just you don't want to sustain it there. These are sustained increases above 1 degree. And this simply shows you the proportion of workers in both conditions that exceeded that WHO or the ACGIH upper limit. Okay, so very simple graph. So over what the workers did in this trial is they exercised for 3 hours. So it's like doing the pre-lunch period. And we used moderate intensity to reflect the same kind of measurements that we've seen in our own field work. But again, you see there's a risk as well in that some will still be seeing increases in core temperature. Okay, reality will be, and the reality that we've seen when we're out in the field is we see a lot of workers that are obese. We see a lot of workers that have type 2 diabetes. We see a lot of workers that have hypertension that are older. The problem is that it's not feasible to always be using the ACGIH guidelines and sitting down there and looking at a temperature and saying, oh, I got to reduce my exposure time. Because when you're out there in the work, what you'll see is the sun comes from behind the clouds. Maybe it's behind the clouds for 30, 40 minutes. Maybe you're working beside a truck or an engine that's generating heat. Things are changing all the time. It's not as simple as simply, looking at a chart and revising your work effort. So when we're doing continuous work in the heat and we have no option, one of the things that we're interested in understanding is what is the safe work limit when temperatures get hot for older workers and those with chronic disease. So what you're looking on the left is the safe work time, and on the right, the tolerance time. So what are the differences? Walk through it with me down here. So safe work time refers to the duration of work before each worker experiences a sustained elevation in core temperature, exceeding recommended limits of 1 degree. Now, the difference with tolerance time is that it indicates the duration of work performed before completing the 180-minute work period or terminating prematurely due to the participant's request of elation over fatigue, or if core temperature exceeded 39.5. So the reality will be if you had a worker that had to go out there, and that's not unlike what we see in the mining industry. They're working at depth, it gets extremely hot, they're working in unventilated air, they got to do the job, and sometimes it requires that they be there continuously. They can't just stop. If they're laying new electrical lines in an emergency, they have no option. They can't just stop and take a break. The work has to be continuous. And what you see is that the safe work times drop dramatically as you get into more extreme heat conditions. And again, the 32 are very different from the 28. And you can see that the safe work times drop dramatically. And again, when we look at tolerance, we see very different responses in the 3 groups. You have over here, you have your older, your young, your diabetic, and your hypertensive. So let's finish off by looking at these last few things. What about diabetes? So what we've looked at thus far is I was telling you about the physiological capacity to dissipate heat and a type 2 diabetic is reduced. Now, this was done in semi-nude conditions. Now we have workers, they're encapsulated with their work uniform. Let's see what happens. Well, see that when we compare the hot condition to the temperate condition, we see that tolerance time goes down. You can see that over here, difference from temperature and exercise tolerance. But here's something to remember. Core temperature, not different. Heart rate, not different. How does this make sense, Glenn, when you just told me that a patient with diabetes has a reduced capacity to dissipate heat, higher core temperature? Well, let me explain to you. You have a worker that essentially is now wearing coveralls. So a healthy worker may sweat more. That's fantastic. They sweat more, but unfortunately that sweat doesn't evaporate because it's encapsulated within that uniform. Great sweater, their clothes are going to get a little more damp. Unfortunately, that doesn't help them. So what you're seeing is because of the uniform impeding heat loss is somewhat of an advantage to that more vulnerable person, because even though they may be sweating less, the person that is probably somewhat vulnerable is going to be that that older person because they're not benefiting from that sweat. They're going to dehydrate more quickly. So one thing to be careful of, if you're monitoring workers using heart rate, that may not tell you the whole story. If you're monitoring core temperature, that may not tell you the whole story because they have the same core temperature, the same heart rate, yet their tolerance time is completely different. And you're going to see that your patient with type 2 diabetes is likely to collapse earlier. And same applies with hypertension. So if I take the semi-nude and look at their capacity to dissipate heat, the only difference here is that we did not see any differences in capacity to dissipate heat in a patient with a hypertension. And this is, again, controlled, uncomplicated hypertension. But what we did see when we have them dressed in their uniforms and doing prolonged work, we did see, again, a reduction in tolerance time. And we also saw that they had the same core temperature and heart rate. So if you are monitoring workers that have hypertension, it's important to understand that while they may have the same heart rate response to doing the same work, they're at greater risk of collapse. All right. And again, this means that if we are going to down the road look at making, readjusting or realigning our exposure limits, we really have to think about how we should make those adjustments for the most vulnerable. And that may be lowering that threshold. So I want to finish off my last slide, folks. I guess I want to ask the question, can we adapt? That's a great question. Can we adapt? Exposure to summer, what our study showed after looking at a person's capacity to dissipate heat, again, conducting the calorimeter pre-summer. So this is done before the summer starts. Post-summer, you see that there's an older person stores way less heat post-summer. So their capacity to dissipate heat increases. However, I want to remind you that during the summer period, temperatures get hotter. So even though there may be some adaptation, remember that the level of heat stress is also rising. So that adaptation still may not be sufficient to protect the most vulnerable, even in the most extreme of conditions. What about a worker? How do we protect workers? Well, in this study here, we showed that when we expose older adults to 7 days of consecutive work in the heat, so exercise in the heat, expose them to high core temperatures, that they can improve their capacity to dissipate heat. Surprisingly, in this paper we published in JAMA, we showed that we can reverse disease-related impairments. So patients with diabetes had an even greater increase in their capacity to dissipate heat, which was quite surprising. So again, there's ways in which we can help workers improve their capacity to dissipate heat so that they are able to compensate more easily. Ultimately, that would mean lower temperatures. So finishing off, I want to thank again my partners at Health Canada who have provided great support for all of this research. And again, we're together working to create these heat resilient communities and workforce. So thank you very much for your attention.
Great. Thank you, Dr. Kenny. That was a really fascinating studies, a couple of studies. We have a few minutes left. Just wondering if the audience has any questions for Dr. Kenny. If you do, please type them in the chat box or feel free to unmute your audio and raise your hand. And just as we're waiting for questions, I'll just put the poll results up. I don't know if you were able to see this, but our first question was asking where the audience was joining us from. And it looks like we have a few from the Atlantic region, many from central Canada and the prairies and also the West Coast. And with the majority of the audience working in public health or for provincial or territorial government ministry. And also in education and research. And over half of the respondents work in their organizations, emergency planning in relation to heat. So the first question we have is, do you have any evidence of differences in tolerance for young children versus adults?
That's an excellent question. We were tasked with assessing that response from Health Canada. And one of the things that, again, there's such a lack of data assessing responses, thermoregulation in children, and there's mixed results in terms of our children that are at greater risk. The evidence, and we do review this in great detail in a review that was published in Medicine, Science, Sports, and Exercise, I think just over a year ago, that there's a real lack of evidence that suggests that children are at greater risk. You know, there's suggestions that essentially they may have a sort of an immature regulatory apparatus or system, but that is not necessarily true. In fact, we do see, and we did a field study assessing heat stress in children, which is also available, open access that you can search out. But again, we did not see differing responses in terms of their tolerance to heat. So I think there is a need for confirmatory studies in terms of looking at capacity to dissipate heat, you know, physiological based studies, because I do think that's important. But as far as based off the evidence that we have, again, it's kind of mixed findings.
Okay, thank you for that. And the next question is, what made our recent BC heat dome driven event that much more dangerous was persistently high nighttime temperatures? With respect to guidance of using cooling centers, might that mean a policy change to enable accommodation for 24-hour operation at those centers? And issues also getting people there. Elderly people tend to want to stay close to home regardless of what it's like.
Yeah, and it's a great question because, again, you know, having my mother in long-term care and having had the opportunity to see the effects of that and the extreme temperatures inside her room, you know, in the way that the patient is you know, brought to the common room to get some cooling. The challenge that we have with cooling centers is that essentially what we don't understand is what is the ramifications of exposing somebody to a cool room. You have to think about the effects of this. And I want to give you an example of workers. What is advocated across the United States, and I see quite commonly amongst workers, is that after especially electrical utility workers that we've assessed, they're so heat stressed. And what they do, they immediately after they finish doing their work, their pull work, they get into their trucks and they run the air conditioning. Think about this. What happens is you're not losing. You're essentially shutting down all of your thermoregulatory system. You're shutting down the sweating response. You're causing vasoconstriction. So all you've done is essentially now create your restricted heat loss. So it may be down the road when we look at these different models, which we're going to be testing soon, is assessing just how much exposure should be, and should we actually be using perhaps slightly warmer temperature to continue to activate the heat loss response while at the same time providing some cooling benefit. Because again, when we look at workers, the minute they go back into the heat, they essentially see the more rapid increase in core temperature, and it actually pushes them much higher. So you've had that residual heat in the body, and now you're adding on to that, and you can see this after rise. So this is why I think, you know, we have to really reevaluate how we implement you know, our practices towards using cooling centers. And the other thing that we have to remember is even just walking to a cooling center, an elderly adult, will cause them to store a heck of a lot of heat. So by the time that they've actually gotten there, sat down and left, they probably only lost the heat that they've gained getting there. That's probably what's happening.
See, great. And we have maybe time for one more question. There are more questions, but I'll email them to you later. The next question is, what are your recommendations to employers regarding ways to mitigate heat stress?
Yeah, and one of those, again, and I was having this discussion before the presentation, and I've had talks with company owners in the United States as an example. And surprisingly, what I get is that heat stress is not a problem because nobody's died. I want to, again, indicate that one of the biggest problems we face is understanding the effects of heat stress in workers and also implementing appropriate heat mitigation. Especially when, you know, workers may not have the luxury of being able to stop work because they have time constraints on them. So in terms of being able to mitigate the effects of heat stress, the one thing, again, in those kind of working environments is using the buddy system, because there's no better way of understanding, you know, how workers responding by having somebody who knows that person well. And the one thing I can tell you, having tested thousands of people, including workers, is that the one thing you see is a change in behavior. Before you even see that level of hyperthermia that's going to affect them, you begin to see an isolation of that person in terms of how they're doing their work. They're ignoring all of the safety rules. So one of the things to do as well, beyond just monitoring, because that can be ineffective, as we saw today, without appropriate understanding of the worker, what their health status is, what their age may be, is to really try to to understand the worker over time. So if you have a worker, it's a document information. And essentially, if you know that you're going to have extreme heat, that maybe it's to create a double team and to essentially plan out, you know, those more intense works and have another team come in and play that in and out like that, as opposed to having one team going in. So there's a lot of different strategies that can be used.
That's great. Those are great considerations. And we do have a couple more questions, but I think that's all we have time for right now. So if you don't mind, I will email you those questions and could answer, yeah, we could post the answers back to everyone. Thank you again, Dr. Kenny, and everyone, thank you for joining us for this great webinar. And the evaluation is available in the chat box right now, but I will email that to you later on today as well. And if you have any questions, please feel free to email. And thank you for joining us again, and have a great rest of the week.
Thank you, everybody.
Thank you. Bye-bye.